Good evening, everyone. It's so great to see so many people here. There's literally people standing. I love this. Thank you so much for joining us this evening for our Healthy Weight Loss event here at Lansdowne for the Arts Club. For those that I have not yet met, my name is Victoria Smart. I'm a wellness presenter, host, and I work very closely with the Beauty Triangle to educate and empower audiences such as yourselves. And I'm really excited to be joined this evening by a panel of 3 experts who are going to be discussing the safe, sustainable, and supportive routes to weight management, because I'm sure we can all agree that this is a conversation that is most definitely increasing in noise at the moment. As the evidence grows and the conversation gets louder, it's really important that we are looking to the implications of these new techniques and medications to ensure that we know the impact on both our body and our mind. And also to appreciate that this is a journey, one that requires preparation, but also aftercare. So those are the things that we are going to be discussing this evening. Before we do, just some housekeeping. You should have each found a programme on your seats. In there you will find further information about our speakers as well as a referral card. So should you wish to be connected with anyone that you hear speak this evening, please just tick the box, pop your email address, and we will connect you following the conversation. You also have a goodie bag to leave with. In there you have some fantastic products by Elastin. One of my most favourite moisturisers are in there, so I highly recommend you take one of those with you. If not, I will be pinching those on the way out. There's also a beautiful serum in there as well. And finally, just a few words about the Beauty Triangle before we begin. The Beauty Triangle was launched 7 years ago now in order to educate and empower audiences about all areas of their well-being, but importantly from a holistic point of view, which is why you'll always find 3 panellists, each of whom are a real expert in their chosen field. But it was also launched in order to connect you, our audiences, with these voices, which brings me very neatly to introduce this evening's speakers. We have functional medicine practitioner, longevity doctor, and general practitioner. There's so many things before your name, Nikita. Dr. Nikita Grover, aesthetic doctor and the founder of now 2 aesthetic clinics. Three.
Sorry, I was on a few weeks ago for my sins. I'm not sure why now.
Dr. Catherine Denning, and consultant plastic surgeon and the founder of Real Clinic in Battersea, Mr. Naveen Cavale. Now that's enough from me. I'm going to hand over to our speakers to say a very quick hello, introduce themselves very briefly, and then we'll get started with the main conversation. Nikita.
So thank you very much, Victoria and Francesca and the Beauty Triangle, and to my fellow panellists here. Very nice to meet you both, and thank you all for coming. So I'm Dr. Nikita Grover, and I've been a general practitioner for about 25 years, and then began to reach a sort of hiatus in my ability to look after patients in the way that I wanted. Really wanted to try and find the root cause to their problems. Many people were coming in with brain fog or fatigue or excessive weight gain, and we didn't really have the answers for them. So I then began to study functional medicine and then went into longevity medicine. And the idea really has been that I'm examining the space between health and disease. What happens in that space? How can we identify patients who are transitioning towards disease early so that we can actually do something about it and change their trajectory? So my focus is very much on preventive health, using conventional and precision functional diagnostics, with an idea that we then provide a very personalised care plan for them to manage them through whatever symptoms they're having and what we're finding on a cellular level. And it's very much a participatory discussion between the patient and myself about what we do, what we choose to use to help them on their journey.
Thank you so much. I'm very excited to hear from you shortly. Catherine?
Hi everybody, it's lovely to be here. Thank you for having me. My name's Dr. Catherine Denning, and my speciality really now is in aesthetic medicine. I would say that the demographic of patients that I see day to day span from 30-year-olds to about 70-year-olds, mainly female, but some male as well. And GLPs have impacted my practice enormously over the last few years. So I feel like I'm in quite a good position to talk about the impacts of GLPs on facial aging, but also a few of the things that we can perhaps do to minimise those impacts and keep skin health at the forefront, despite some of the changes that we see with rapid and extreme weight loss. So yes, we'll be talking a little bit further about that afterwards.
Thank you, Catherine. And Naveen.
Hi, yeah, and thank you again for having me. I'm Nav Cavale. I'm a plastic surgeon based here in London, and I'm kind of, traditionally I'm the polar opposite in terms of I'm not the preventative person. I'm traditionally viewed as the it's too late, right? So now what do I do? And cut it out and stitch it person. But we've evolved, I'd like to think. So I'm a surgeon that definitely works with aesthetic practitioners, and any decent plastic surgeon, cosmetic surgeon, aesthetic surgeon, whatever you want to call us, will not just work in isolation and cut and stitch, which is kind of what used to happen. We now work alongside. So at the Real Clinic, we've got aesthetic practitioners, we've got a weight loss clinic, we've got other surgeons, we've got GPs, dermatologists. So we're now holistic, hopefully, and as well as that, my private practice is pretty much aesthetics. I still work in the NHS very part-time, but I do reconstructive surgery, so I do a lot of abdominal wall reconstruction, complex, but general plastic surgery. I've got a charity hat, so I used to go to Gaza a lot when I used to be relatively safe. I haven't been for a while. I teach medical students, I teach business, I run a business because the clinic is a business. And I'm very interested, actually, I tell you what, in terms of how to work alongside people like Nikita, because we probably haven't quite evolved into that as surgeons. So yeah, I think interesting panel. Thank you for having me.
Thank you. Very, very excited to start picking all of your brains. Nikita, I'm going to start with you. You mentioned that you take a very holistic approach and you work personally with the people that are in front of you. Could you start by explaining exactly who that person usually is and the kind of complaints that they turn up with at your clinic?
So very often see people with chronic fatigue, resistant weight gain, people who may have been overweight for years and they've tried everything, they've spent thousands of pounds on weight loss programs, on fasting programs at our famous Lanzerhof clinics, and they do lose weight, and it doesn't matter what you do from a caloric restriction point of view, you're going to lose weight, but it's what happens afterwards. See patients with brain fog, irritable bowel syndrome, autoimmune diseases, a whole spectrum of conditions, as well as chronic diseases such as diabetes, cardiovascular disease, blood pressure problems, brain fog, post-COVID related problems. So a lot of problems that have been classically identified as medically unexplained symptoms. The sort of symptoms that many of us may have gone to our GP about, have even seen specialists, been investigated a gazillion times, told everything's normal, but something just doesn't feel right. Your intuition tells you it's not right. And that's where taking a deep dive with functional medicine can be quite helpful.
We're here this evening to discuss weight loss and actually, like you say, weight gain. Who are the people that are struggling to lose that weight? And you mentioned that people turn up with this reluctant weight that doesn't want to leave. What do you find that the reasons for that usually are?
So it's multifactorial, okay, and I think that with any discussion about weight, we've got to think about three main pillars. The first is genetics. So if you're from a family history who are overweight or very slim, you're likely to genetically be on that spectrum. There will be some ability to dial that up or down, but you're always going to be within a particular spectrum. And it's not one specific gene, it's usually what we call polygenic, so a number of genes that can determine that weight. There's also lifestyle, and that's the piece that we all speak to, and that very much depends on nutrition. And again, everybody knows about ultra-high processed foods, but there's also how we eat, when we eat, whether we're eating, the main meals at the beginning of the day when it's in accordance with our digestive system. Also how much we're moving, the type of exercise that we're doing, how good or bad our sleep is. So that will have a huge effect on weight gain. So anything that stresses our system, including stress and the company we keep. So, who we live with, where we live, will also have an effect. And the third pillar is the environment. And we are now bombarded by persistent organic pollutants. So in till receipts, in plastics, all of those things which are actually endocrine disruptors. They're obesogenic, obesogenic chemicals. They are making us fat. And those things also exist in our food.
I remember learning about receipts, and every time I went to Tesco's now, I pinch it with my fingers because I'm so terrified of just a receipt. You mentioned their genetics. Where does testing come into this? Because if someone's turning up at your clinic, we wouldn't know, would we, about our genes. What role does testing play when you're trying to discover the root cause of this?
So I think genetics is helpful to a point, but actually what I tend to be more interested in for my patients is moving the dial on the things that we can change. So fine to know if you're interested, but it doesn't mean that that's the position that you're always going to have to be in. You can change and you can still be healthy. You can still have a healthy metabolism. Your hormones can still be healthy, even with a genetic predisposition. And I think that's the important thing to understand.
So when a patient comes into your clinic, where do you begin? If you're saying that it's lifestyle, do you start with those things and then you start to consider medications like the GLP-1s that we're speaking about at the moment?
So I begin where they're at. If they're not presenting with a weight problem, then I'm not going to suggest that we tackle that. We'll start with whatever the issue is. So if it's, for example, a lady in perimenopause who is eating exactly the same and feels she's eating healthily, exercising exactly the same way, but feels as though she's gaining pounds and can't shift it, that's where we'll start. We'll look at her hormones, we'll look at her gut function, we'll look at her nutrient content in her blood, and we'll then try and put a picture of how is her physiology actually functioning, and if there's a problem with her metabolic function, for example, she's got some insulin resistance or her cholesterol is up, then that will be our starting point for the metabolic conversation. We'll look at body composition, very, very important. So if you're holding on to visceral fat, which is the fat that's inside the abdomen, so not the fat that you can pinch, which is a subcutaneous fat, which Naveen would be able to suck out with liposuction, but that has no impact on your metabolic health. That's just sucking out superficial fat. It's not changing your metrics. Okay. Sorry, I forgot what your question was.
No, where do you begin? And the next question is going to be, at what point do you suggest that GLP-1s are important? So I'm interested to know what steps you take before you get there.
Yes, so very much looking at nutrients, and that's because thanks to a very amazing piece of research that in fact our nutritionist Nita has done here, the only piece of research in the UK looking at nutritional deficiencies with people on GLP-1s. So we look at their nutrients, particularly vitamin D, iron, magnesium, zinc, selenium, all the micronutrients are looked at. We look at their hormones. It could be that they've gained weight because they've got hypothyroidism developing. And so we look at their cortisol and their stress levels, because actually we know that when you're stressed, you gain weight because it's your safety blanket. It's really important that we address those side of things, and there's lots of ways that we can do that too. And we also look at gut function, because we know that the populations of microbes that we have within our gut also determine our weight. You can transpose gut from a thin mouse to a fat mouse, and a fat mouse to a thin mouse, and you'll change the way those mice, you'll change the weight in those mice. So we know that there's something in the microbiome that helps determine weight, and we've identified that quite closely now. So we tend to look at those, and a lot of people will have an absence of a particular bacteria called Akkermansia, which many of you may or may not have heard of, and we can think about diet to try and help increase those levels, or even probiotics if needs be.
What in our diet can help increase that bacteria?
So fibre, very much fibre. And interestingly, from the nutrition research, 100% of the people being on GLP-1s had less than the requirement for fibre.
Wow.
So it's a really, really important, it's not really defined as a nutrient, but it's a really important factor. Protein's really important as well. So, people weren't meeting their protein targets, and we'll come on to side effects and things, I'm sure, but that's really important as well. Vitamin D, only 5% of people who were on a GLP-1 actually met their vitamin D optimal target. For iron, it was about 80% weren't meeting their target. So you can just see how then when you're not consuming nutrients because your appetite's been suppressed from the GLP-1, you then start being in a process of attrition, effectively. So that's important.
We will come on to the impact and the side effects shortly,
Yeah.
but could you actually explain to us exactly what GLP-1 medications are and what they're doing within the body?
Yes. So GLP-1 medications are biosimilar medications. They're augmenting a hormone that is naturally produced within our intestines. So that's glucagon-like peptide and glucose-dependent insulinotropic polypeptide. Those are the two. And so they were originally discovered in this sort of lizard called the Gila monster back in 1992. So it's not just humans that have GLP-1, it's also other animal species. And the Gila monster's GLP-1 lasts for about 30 days, but ours is only 2 to 3 minutes. So after you eat, GLP-1 is released, and it lasts about 2 to 3 minutes, and it increases satiety, it slows down your digestion, and it increases insulin sensitivity in the pancreas. So it's affecting the gut, the brain, and the pancreas. And so those drugs are mimicking those effects, and they're dosed usually, if it's an injectable, every week. So that's essentially what those drugs are.
I find it really fascinating about the Gila monster because they only eat like twice a year,
Yeah.
and they're so satisfied that they only need 2 meals a year. That sounds lovely. What's the difference between the different types of GLP-1 medications that we are hearing about? We're hearing so many different names: Wegovy, Ozempic. Can you start explaining the difference between those and which one might be right?
Absolutely. So semaglutide, which is essentially Ozempic and Wegovy, just contains one form of GLP, so it literally is GLP, glucagon-like peptide. The second generation ones, which are Mounjaro, they contain 2 types, and it's meant to be slightly more effective in terms of weight loss. So we're looking at about 7 to 10% weight loss, which is less than what the trials show. But when you look at the trials, they actually optimised diet. They had a lot of nutritional support and that sort of thing. So you're looking at about 7 to 10%, I would predict on that. So those are the 2 main types. There are more coming out on the market, which maybe we can talk about later. And then there's oral forms, which can be taken daily. But essentially, it's either an injectable or an oral form.
And who are the people that aren't able to take these? We've spoken a lot about the impact, but actually, at what point do you say this isn't right for you? How do you dictate that in your clinic?
So there are some absolute contraindications. So pregnancy would be one of them. If someone has had a history of a cancer, so usually thyroid cancer or a multiple endocrine neoplasia, so something affecting lots of hormones. If they've got an eating disorder, if they've had pancreatitis, which is a very serious inflammation of the pancreas gland, and if they've got any serious mental health disorder, then that would also be something that I would probably exclude them from having it, just so that we're not causing more problems. So those would be probably the main exclusions.
And when it comes to the impact, because obviously I'm sure most of us know that these are originally for people that have diabetes or diseases alike. What is it showing? What is the evidence showing us that actually it's supporting with other metabolic or inflammatory diseases? What are you seeing at the moment?
Yeah, so we must remember that the studies are done on people who are clinically obese or have diabetes. So those are the populations that are studied, and they aren't most of the people who are actually on the drugs. And so in those studies, what we've seen is that there was a select study which looked at cardiovascular disease and showed that in those populations there was a massive reduction in heart attack, stroke, and cardiovascular events. There's also been a study looking, called the FLOW study, looking at the effects of taking a GLP-1 when you have renal disease from being diabetic, and that shows an improvement in renal disease. There's a study looking at, I think it's a step 9 study, looking at osteoarthritis and joint pains, and that's also shown quite a reduction in joint symptoms. So an anti-inflammatory effect, essentially. There's also ongoing studies looking at Alzheimer's, and so there's certainly very big, strong signals saying these are having pleiotropic effects, meaning multiple effects in lots of different areas, affecting health.
Can you explain a little bit about what the journey looks like? Because I mentioned at the beginning that actually I feel like everyone hears this idea of weight loss and they go, absolutely sign me up. But actually, as a practitioner, how do you take your patients on this journey? What do they have to do to prepare to take these medications?
So the first thing is optimise nutrients. The second thing is to look at whether they're moving and exercising, because we know that there's a 25 to 40% muscle loss with these drugs if you're not maintaining adequate protein intake, and if you're not doing strength exercise, so you're not actually giving yourself the stimulus to build muscle. If you're not optimizing your hormones, so if you again don't have the hormonal signal that will allow you to take protein in and get the benefits of exercise, be that through testosterone or estrogen, depending on where you are in your life cycle, that's important too. So I would take a patient through those aspects. And very important, nutrition. Look at, what are they eating and all of the things that we've discussed before to make sure that aspect of it is good. We might want to, give them a continuous glucose monitor for a while and see what's happening. Is the main issue actually not to do with what they're eating, but their stress or the fact they're not sleeping at night? So if their glucose is going up and their biomarkers or insulin are going up at night, then actually food isn't going to be the issue. We do need to look at their sleep. So we take a holistic view. So history, blood tests, and then have a discussion about what is it we're trying to achieve. Have we got evidence that there is metabolic dysfunction, in which case would a GLP-1 potentially be a really good option?
And it's really interesting, that last question that you asked there. Is it the right option for that patient?
Yeah.
And my ears pricked up when you said glucose monitor, because I'm wearing one and I can see it fluctuating throughout the night. I'd like to know a little bit more about how you're guiding them on the journey once they've started, because I know we've spoken offline about horror stories of people turning up with these things in their bags. You can source them almost anywhere, which is the most terrifying thing about these medications. How do you educate your patients if they are turning up and saying, I've already got them? How do you say to them, let's take this journey together? And what do you do as a practitioner to ensure they're safe on that journey?
Yeah, no, so absolutely, it's a conversation. Victoria and I were having a chat before a couple of days ago, and I was just recounting a story where a patient of mine came to me with a freezer bag of 5 what looked like diabetic syringes. So they're 1 ml syringes, each with a clear liquid in, not labelled. And then on the freezer bag was a sticky label saying retatrutide, which is a 3rd generation GLP medication, which is not yet licensed in the UK, which they'd obtained from a clinic. And she said, I just spent £1,000, what do you think? So it's a conversation. So the first thing I said is, I have no idea what's in those syringes, and neither do you. And personally, I wouldn't inject that in myself, and I don't think you should be either. Then we talk about, what is the issue? Okay, is it weight? Is it a body, a dysmorphism, or a sense of lack of confidence? We need to go into the psychology of what actually is the issue, and metabolically what is the issue? What are the issues? And then see where they're at. if they're prepared to have the conversation. And she was, because that's why she was there. There was, her inner intuition was telling her this is not the right thing to do. So we have a conversation. I make people aware of the risks and benefits, the side effects of being on the medications, the things that you're going to experience when you first start. So the nausea, the dehydration, the constipation, potentially hair loss, the muscle loss. It's no such thing as a free lunch. And then we have that conversation, and then at the end of the day, it's up to the individual to decide. I am there to help and assist and to guide, and if that's what she decides to do, she hasn't been back, so I'm not sure.
Oh, no.
Then we can talk about it. On the other hand, I've got a patient she's got a BMI of 34, so she hasn't hit the NHS guidelines for being prescribed Mounjaro. She's started on it, and she said, "Oh my goodness, my face has suddenly got really thin," and she's still of a size, and she said, "I've decided to go really, really slow." And I was like, "Okay, great. How slow are you going?" And there's sort of 60 clicks for a 2.5 syringe, so she's on the lowest dose. And she said, "Oh, I've just taken 5 clicks," which is a tiny, tiny amount. And she said, "You know what's happened? I feel as though my mood is better. I'm not so worried about my weight." She said, "I feel I have energy, and I don't want to go up any higher." So everybody is individual. It's about drilling down into why are you taking this medication? What are we trying to solve? And what is the best route to be able to try and do that? And just try and help them.
You mentioned psychology, which is a really important part of this, and going on this journey with a practitioner also is the most important part, being supported throughout the whole of that journey. Once someone's been on that journey, what does it look like afterwards? What does aftercare look like? Is this something that people are taking forever, or is there a time that you can actually step away from these medications and say you're at a space where you'd like to be, and then you maintain it in other ways?
No, it's a good question, and it's a difficult one to answer because it's slightly how long is a piece of string. And we're still sort of finding our way in some sense. So for people that may have a lot of weight to lose and are metabolically really not in a good place, they might well be on it longer than someone that perhaps has less weight to lose and is otherwise okay. The psychology is important, especially given the fact that certainly the trial data suggests that at 12 months for those people that stop, 12 months later, they will have gained 2/3 of the weight that they originally lost. So I think putting the lifestyle practices in is really, really important, because I don't want to end up with a patient in front of me who, we're trying to make them metabolically healthy by putting them on the GLP-1, and all that's happened is that they're nutritionally in a bad place. They've lost muscle. Muscle is an endocrine organ and consumes 80% of their insulin. And all we've done is made them actually metabolically worse. And muscle is also very important for your brain health and your psychological function. So, we've got to tread really, really carefully. The evidence in terms of psychology, psychological health, currently there was a big trial, I think 2025, suggesting that actually mood is much improved, anxiety is improved with GLP-1s, obviously food noise, and a lot of addiction behaviours. There's an alcohol study as well suggesting that, dependence can improve. It doesn't seem to be reducing your enjoyment of food, but it can, just dumb down that noise a little bit too. There is actually a separate study, it's an observational one, which is much smaller, that does suggest that in a certain group of people, actually it can make psychological disorders worse. Wow. So again, we've got to just be really careful and keep looking at what the research is telling us.
And it's an important point, isn't it? The research is developing.
Absolutely.
We're not quite there yet, actually.
Yeah.
We're hearing more and more about it, but actually the research isn't quite there to know everything at all. And I guess that's a risk that your patients take, but also you take as a practitioner, and saying, we don't know everything yet, but this is a journey that we're on together.
Completely, and that's why there needs to be full transparency, because as doctors prescribing unlicensed medications, off-label medications, we are taking a risk. We are doing it in patients' absolute best interests, but there's a lot here about these drugs, because they are so new to market, that's still unknown. And we're hearing all the sensational stories, which is great, and they do work. It's hope in a vial for a lot of people. They haven't been able to lose weight, or they've always been overweight, and finally there's something that's come along that's changed that. But just that word of caution, and just that word of good lifestyle practice to back that up.
It's caution, it's as you say. And just finally, what does the future of GLP-1s look like to you? Is there anything that you're seeing that is exciting, or anything that we should be wary of?
Buy shares.
Noted.
Look, they are here to stay, and the market is just ramping up. So retatrutide, difficult to get my false teeth around that one, is going to be out soon. In fact, as I say, it's already kind of on the black market. So please, guys, go with caution. There's another preparation coming out, CagriSema, I think it's called, that's got amylin, which is another type of insulin sensitizing hormone, together with a GLP that's coming out. There's also small molecules, something called Foundeo. That's not based on, it's not a biosimilar, so it's not based on a real natural molecule that we produce ourselves. And because it's synthetic and artificial, I would be very cautious about that, because that's going to be potentially treated as a toxin. That's going to end up being metabolized through the liver, and who knows what's going to happen downstream of that. So I'm very cautious about that. I think probably it's going to be the older ones that have the most evidence behind them that are going to gain the traction and be, utilised more freely. Yeah.
Thank you so much, Nikita. I have so many more questions, but I'll save those for the end. Thank you so much. That was fascinating. Thank you. Catherine.
Hello.
So we've spoken a little bit about the journey, and it's something I mentioned at the beginning and something I'll keep coming back to, because that is actually what we should be doing when it comes to going on a journey with a practitioner. Where does the journey begin with you? What are your patients seeking when they come into their clinic, and what part of that journey are they at?
So I would say the vast majority of patients that come to see me that are on a GLP journey, many of them are existing patients. And what's very interesting is, sort of for about maybe a year and a half or so, I can almost always tell when someone started on a GLP as soon as they walk through the door. And that's because there's this very, and in medicine we say pathognomonic, and what I mean by that is that there's this very standard pattern that you see of a facial change of someone that has started on a GLP-1. And especially if they've gone down the rapid weight loss approach, and as Nikita quite rightly said, not everyone does. But even those that don't go down that rapid approach but are on a GLP-1, they still tend to get this very obvious facial change that you see walking through the door. So I can almost always, I'll go into what that is, but it's very interesting because a lot of my patients I've known for a long time. I've been doing this for sort of 12 years now, and a lot of them have been lifelong patients so far, and for them to suddenly come through the door, and the things that I notice are, and I'll go into the reasons why in a second, but it's very significant temporal hollowing, so hollowing in the temple region of the face, hollowing under the eye, and in what we call the mid cheek, or the front of the cheek just here, and hollowing in this sort of area, or the buccal area, or the area just in front of the ear. And the reason that we see that is because obviously these people are taking GLP-1s for weight loss, for fat loss specifically. Although Nikita's absolutely right, there is other tissue being lost there, and we'll go into a little bit about how that also affects the face and the skin. But essentially they're losing fat from their face in the same way that they're losing fat from their thighs, from their abdomen, whatever. And facial fat has an extremely important function structurally in the face, and whenever I'm talking to patients, I break down the face into 5 main layers. and Nav will laugh at me because I simplify it so much. But we start with the deepest layer, which is the bone. You then have a deep layer of fat. You then have a layer of muscle and fascia. And then you have a superficial layer of fat, and then you have skin, okay? And every single one of those layers can, if you're not careful, be affected by GLP-1 use. But the most significant change is in the fat. So that deep layer of fat, that superficial layer of fat, it's very obvious. The other thing that I notice is the skin changes in texture, and it changes in radiance. And that's something that I don't think we really sort of hear or talk about enough. It'd be interesting to see what you think about this, Nav, and your patients that are on these medications and when you operate upon them, because the fat that's actually within the dermis of the skin, so your skin you can split into epidermis and dermis, like roughly, epidermis being the top layer of that sort of, not dead, but sort of dead layer of skin on top, and then your dermis, which is much more metabolically functioning layer of skin and has all the organs and the hair cells and the glands and everything like that. But it also has a layer of fat called the dermal white adipose tissue, so the DWAT. And there's been some absolutely amazing studies coming out in the last year. In fact, in the last 2 weeks, there's been another fantastic one come out by Sabrina Fabi, who's a dermatologist in the US. And what they're doing is they're biopsying patients, so taking a little bit of tissue from the patients that are on GLP-1s and that aren't on GLP-1s, and comparing essentially what they're seeing under a microscope. So histologically speaking, what's different? And what's really different is that the DWAT layer is significantly impacted by GLPs, not just because it thins, but it also changes metabolically. So things like the stem cells that are very important in the fat in your skin and elsewhere, but in the fat in your skin, they're very important for skin health. And what we're seeing in people actively on GLPs is that those stem cells disappear completely. So Nav and I were talking earlier, and it's an interesting question. Does that then mean that even when you come off your GLPs, you're going to continue to age more rapidly? It's a good question. We don't know. But I guess the thing for me then is, how can I then support my patients? And I want to just put my hand up and say, I think GLPs are one of the most revolutionary drugs, and yes, they absolutely have negative impacts and they have to be used with caution. But the vast majority of my patients, and I would say most of them, are probably appropriately on them, to be honest with you, but there are definitely patients that aren't. Yeah. And even the patients that aren't, the psychological and emotional impact of being on these drugs has just been unbelievably positive for them. And it's things, as Nikita said, like food noise, the just general mood elevation. Obviously, losing weight has health benefits as well, alongside the benefits of GLP. So I just want to caveat by saying that I absolutely do not think that they are negatively impacting everything. But what we do know is that they're negatively impacting the aging of the face and particularly the skin.
So interesting.
Yeah.
I love the way that you describe our faces. I never knew what was going on beneath the surface. Someone once said it was like a cake, and now I constantly think about that. There's so many layers within the face. I don't really know where to start. Where do you start when someone comes in? What is the first go-to? How do you start analysing what part of the face needs addressing?
Yeah, so it's a great question, and I have to say that I completely agree with everything Nikita said. A holistic approach is absolutely key. So I do not prescribe GLPs. We don't have a GLP service. It's something I'm thinking about introducing, actually, purely because then I can, much to Nikita's way, almost make sure that they're being given the right advice alongside this weight loss program. That's another matter. But ensuring that they are under the care of a dietitian, have a good, let's say, PT that can help them manage through things like muscle loss, because Nikita's absolutely right, that's also extremely important metabolically and generally aging-wise for the body, but also for the face. So that's a sort of starter, and we don't do any of that in the clinic, but it's something that we help facilitate. And now that I've met Nikita, they're all going to be going to her. And then we start to approach, okay, so looking at this person that started on this GLP, where are they in that journey? Because we also know that if they're very far down their weight loss journey, that will impact enormously the results that they can get from aesthetic treatments. And essentially there'll be things that there's just no point in doing. So if they've come relatively early in their journey, I do encourage quite a proactive mindset in terms of aesthetic treatments, because we've had data from this year from coming out of South Africa and the US that suggests that the more proactive you are in stimulating tissue to help with that, things like the stem cell activation and trying to increase collagen, elastin, adipose tissue in the face that's being lost through GLP use, the sooner you start that, the better, essentially.
And is that what we hear when we're speaking about regeneration, which is what we're hearing a lot more now in aesthetics?
So in my practice, we have a relatively sort of a layer by layer approach, to be honest with you, and a lot of it's regenerative and some of it isn't. So again, I think of everything in layers, and if there's a volume loss issue, which inevitably there will be, then really the best thing for that is some form of revolumizer, i.e. I use a lot of hyaluronic acid fillers, very small amounts, very strategically placed, replacing that volume loss in the temples, in the midface, in the preauricular region, as an example, in the tear trough region. Because there isn't really anything, and Nav and I very briefly spoke about fat transfers earlier, and I love fat transfers, don't get me wrong, and I do have a plastics background, so I do understand it, but in the context of GLPs, you're then going to have fat in the face that's behaving differently because there's GLP in the system. So I actually tend to go down the HA filler route to revolumize deep and superficial fat pads. But really, the skin is the bit that needs the regeneration, generally speaking. So what we're trying to do there is get the body's own cells to do the work. And, and so things like, I use a lot of Sculptra in my practice. Now, Sculptra it's been around for 25 years. It's a product that is a bit of a Marmite product within medicine. Some surgeons love it, some surgeons hate it. Aesthetic practitioners tend to love it because you get fantastic results. But essentially what it's doing, and we've got some amazing epigenetic studies from a dermatologist called Jill Weibel out of the USA, and also from South Africa. And what they've done is, again, biopsy studies and looked at the gene expression before using Sculptra and after using, so they did a split. How they got patients to agree to this, I don't know. They did biopsies on each side of the face and treated one side. So anyway, they must have paid them or something, I don't know. But what they saw is that Sculptra acts genetically on the genes, and it acts on lots of different genes. So it acts on anti-inflammatory genes, it acts on pro-collagen genes, it acts on, and elastin, and Nav will attest to this. Elastin is almost impossible to regenerate. It's a really difficult protein to get your body to make, but then also to keep in the skin. But one thing that we know elastin does is it activates something called tropoelastin, which then joins together to make elastin chains. And it's something that it can do very effectively, partly because it's working on all these other genetic profiles to help things like the anti-inflammatory environment. So if you've got a very pro-inflammatory environment, there's no way you'll make elastin, essentially. You can make collagen, type 1, type 3 collagen, fine, but elastin's very difficult to do. So it does that very well. But for me, the key thing is it acts upon that adiponectin and the adipocytes to regenerate adipocytes and convert immature adipocytes into mature adipocytes, and those kind of surrounding factors that help, and again the stem cell factors and things like that to help. So for me, in terms of my patients' skin health, that's a huge thing, because there's nothing else really on the market that we know that does that.
And is this what we're hearing, collagen stimulators?
So collagen is one thing in our extracellular matrix that makes our skin bouncy and healthy and whatever. And it's obviously very important. And type 1 collagen is the collagen that we want to have in our skin to make it look. And Francesca and I earlier were talking about our babies and how much beautiful collagen they've got in their bouncy cheeks. They're like the best advert ever for collagen. But it's one element. So really we should be thinking not just about collagen, and yes, it's important. And again, it comes into the dietary elements and also the exercise elements to help support that as well, because there's no point in giving all these regenerative treatments, but then not supporting that functionally with the proteins that will enable that. But we also need to be thinking about elastin. We need to be thinking, especially with GLP-1 use, adipocytes, which I just think isn't spoken about at all. So generally my patients will get deep layer volumization with HA filler. Almost all of them will get a sculpture treatment. It's the most research done in any regenerative treatment by quite a long way. And then obviously skincare is so important. So I use a lot of peptide-based skin cares. And actually, I'm really excited that you guys have got a bit of elastin in your bag, because this is basically my favourite. But by being able to, again, epigenetic studies, it's fantastic at stimulating those things. So if you're then feeding the skin with as much of that goodness as possible, and stimulating as much as possible as early on in the journey, that's the way that you're going to sort of minimise, I guess, the ageing impact on the skin.
And that's all the layers of the cake that you've spoken about there. Yeah. Two things I'd like to pick up on. Firstly, a little bit more about elastin, because I can also attest, I absolutely adore that moisturiser. Yeah. But also back to fillers, because I think we often hear that fillers are gone, people don't want to have fillers. Yeah. Can you just explain why you are still using fillers and why it's such an important part of your practice?
Do you know what? I completely understand people's reticence and fear around filler. I completely understand it. I'd say less so as medical practitioners, but absolutely medical practitioners, but just the general environment of aesthetics have completely lost public interest and what's the word? Trust in fillers, because some of the results you see are absolutely appalling. They're just, in my view, disfigure people. It can be very aging if it's used inappropriately. That being said, and I say the 4 Ps, the right practitioner, the right product, because that's really, really important, in the right place, on the right patient. Actually, there's nothing really that replaces HA filler for revolumizing. And as long as it's used appropriately, and in my clinic we don't do much of the beautification, we don't do the enhanced lips, we do restoration work. So we do weight loss, we do a lot of menopausal patients, because actually it's a very similar aging process when you look at GLP-1s versus, for instance, the menopausal process in terms of what happens in the face. It's very similar. So we use a lot in small amounts.
You mentioned there a combination approach. You're using, all these things together. Is that the safest thing for people to do, to have that regenerative approach?
I mean, honestly, like with anything in life, I think if you can try and be as holistic about your approach as possible, that's the best way to do things. So if you can try and every layer of that face, of that cake, and approach it by different parameters and different metrics, you're going to have a synergistic effect. And funny enough, I actually gave a talk in Monaco recently about the synergistic effect of sculpture with elastin. So, and the reason for that is because they work on a very interesting combination of genetic, the impact that they have on genetic expression of things in the skin, and we know that it's synergistic. So, and synergistic, for those that don't know, the definition just means purely that it's 1 + 1 = 5, as opposed to 1 + 1 = 2. And so we know we can get better results. I then often will combine that with energy devices, with laser treatments, with radiofrequency microneedling to tighten the skin, things like that. But ultimately, the regeneration comes from that genetic level, basically, yeah.
And where do skin boosters come into this? Because we're also hearing more and more about skin boosters, and you mentioned at the beginning the tone of the skin, it looks dull, it looks dry.
Yeah, absolutely.
How do you use skin boosters in your clinic for people that want GLP-1s?
So skin boosters also play quite a big role, largely in hydration. So I use, it's the only one on the market that's what we call cross-linked. So they're by Restylane, it's called Restylane Vital, and Restylane Vital Light, and because they're very mildly cross-linked, it means it doesn't get broken down in the skin very quickly. So if you look at pure hyaluronic acid skin boosters, they actually get broken down in the skin within a matter of days to weeks. We think maybe even days. Pure hyaluronic acid looks a bit like cotton wool. If you mix it with water, that lasts in the skin a matter of minutes to hours. So the more you can stabilise that molecular structure, the longer it's going to last in the skin. So if you can get the bonds between the molecules to be slightly stronger, so they almost sit there between a skin booster and a filler, sort of, although they do fall into the skin booster category.
And just for clarity, what is a skin booster, what we're speaking about here?
Yeah, so skin boosters, to be honest, there's a range of definition for skin booster. How I define a skin booster is that it's usually hyaluronic acid based, because there's plenty that aren't. And some of them will have amino acids in them as well, and some of them will have other compounds, but largely it's hyaluronic acid based. And you're really injecting them mainly for hydration. There's some evidence that it also helps stimulate collagen, although I wouldn't necessarily use it for that purpose, because we have the likes of sculpture and laser and things to do it much better. But mostly people like it because it gives a little bit of structure back, and I mentioned before that the skin becomes dull and lacks luminosity. The other thing that happens, because they've lost that adipose layer in the dermis, is that it becomes you see a lot of elastosis, and what that looks like is that sort of, you get lots of little fine lines almost around the mouth, and then especially on expression, and it makes the skin look quite textured. So if you can then introduce hydration, and again that extracellular matrix that's in the dermis that's so important for skin health and support, hyaluronic acid plays a huge part in that. So if you can replace that longer term, that's also beneficial.
And finally, the very top layer, skincare. You've mentioned elastin. What role does skincare play, and what can we be doing from home outside of your clinic?
So, I mean, skincare, I give the analogy to my patients of almost, let's say that I'm a dentist, and you come to see me, and you have a filling. If you then don't go home and brush your teeth every day, there's absolutely no point in coming to spend money on coming to see me for your filling. I'm not a dentist, just to clarify, I don't do any fillings. But that analogy stays quite strong, because actually, if you're not looking after skin health day to day, then it's irrelevant what you're doing in the clinic, to be completely honest. So at a basic level, everyone should be using sunscreen, everyone should be using an antioxidant, and everyone should be using some form of vitamin A. Some form, not everyone tolerates vitamin A very well, because we have extremely good data that is age protective and age reversing. And then the next layer of that then is peptides. So we look at various, there are various peptides on the market. Again, one of the most studied is the elastin range. So the genetic expression studies on that is just absolutely incredible, and the biopsy studies on that. And it has a fantastic range as well. You can get a vitamin C, you can get a hyaluronic acid, you can get a pigment suppressing version. So it's just a nice, and it's lovely to use. So my patients just love it, and it looks really nice on their wash stand as well. It always helps.
It's very chic. And before we finish, I'd finally like to touch on body. Are patients coming with body concerns as well into your clinic? Is this something that you're seeing too, not just in the face?
Yes. So I mean, listen, I predominantly treat face, neck, and décolletage, but I have to say I'm doing more and more body treatments now, purely because of the demand from GLP weight loss, and we look at abdominal, arms, knees. People come in wanting skin tightening on their knees. It's fascinating.
Wow.
And again, I take exactly the same approach. Whilst they're not necessarily all the same layers in the face, it's very often very similar. So things like use of sculpture alongside radiofrequency microneedling, gives them some fantastic skin strengthening and things. And actually, interestingly, I get a lot of post-abdominoplasty patients come in, and actually what we find is that the ongoing care after abdominoplasty is a great way to keep that skin looking nice and tight, because Nav will tell us it's fantastic. You get a fantastic result with the abdominoplasty, but then in 5 years' time or something, you start getting skin laxity again, or if they gain and lose weight again. So again, it's quite a nice kind of post-surgical and pre-surgical preparation for skin strength.
I'd be more paranoid about my knees.
Honestly, I never thought of it as being a problem, but it's actually quite common. People come in, they're like, I don't like how saggy my knees look.
And now you can inject injectable regeneration into your knees. That's really fascinating.
Yeah, so yeah, exactly. Yeah.
Thank you so much, Catherine. That was
Pleasure,
really interesting.
absolute pleasure.
Thank you. And finally, last but not least, Naveen. So Nav, you actually spoke about your clinic, but actually your clinic is more like a hospital. I feel like the word clinic doesn't quite do it justice. It is a hospital. You have several operating theatres. I cycle past it every day, which is always really good fun. Who are the people that are turning up at your door? At what point in the journey are they at, and what are they seeking?
So we have people turning up at all parts of the journey, because we are an holistic clinic in that sense, in that we've got surgeons, we've got aesthetic people, we've got skincare-ish, we've got weight loss as well, we've got a physician who is prescribing GLP-1 agonists, so we're trying to do it doctor-led, nurse-supported, And so as a result, we've got all sorts. I mean, in my practice, I've got all the people that we've heard being described so far at different points of their journey. The ones that I end up operating on, which I guess is what we'll talk about, so we're going to dumb down this discussion hugely. There are not going to be many molecules or long names.
So I think I went into a bit too much there, didn't I? Sorry now.
And I'm such a simple soul. But we have people who effectively have perhaps it's a bit too late, they're a bit too old, they have not had GLP-1s, they have lost weight through some of the older ways, but gastric banding, gastric bypasses, those sort of things. So and I'm therefore seeing people with loose skin because rapid weight loss, it doesn't really matter how you lose weight, whether it's through surgery, through a gastric band or through GLP-1s, will cause loose skin. Rapid weight gain, no matter how you do it, by having a metabolic condition or just by eating too much and not exercising enough, if you gain weight too quickly, you get stretch marks. It's as simple as that. And so you will end up with loose skin if you've lost weight really quickly, and loads of us have done that over, we were pregnant and we're not pregnant, we gained weight, we lost weight, we were really fit and exercising and life took over, or life changed, and we've lost lots of weight. So in my practice, I see a steady stream, and it's in that sense it's no different without GLP-1s of people who've lost weight really quickly. And that's an interesting conversation to have, actually, because I think if you're going to lose weight, do it slowly. If you're going to deflate a balloon, deflate it slowly. Don't just let all the air out, otherwise it will be really flabby. If you let a little bit of air, wait a minute, a little bit more air, wait a minute, a little bit more air until it's deflated, it will be tighter. Skin does not like being deflated quickly. So I think the message you've heard in terms of the GLP-1s and weight loss generally, no matter how you're going to do it, ought to be done nice, steady, slowly. And I guess what kind of people am I seeing? I'm seeing all sorts.
I feel like people are being a little bit more open about surgery these days. We're seeing more and more people, especially in newspapers, online, saying, I have had surgery. Do you think the taboo is changing around surgical intervention?
Yes, totally, and that's such a good thing, because the biggest change, for example, a really good example to use is facelifts. Okay, if everyone here probably thinks of facelifts as those weird people, the Bride of Wildenstein, or people who've had, Nancy Reagan was a classic example, probably had a facelift every other week, a little bit of skin, nipped, lunchtime tuck, and just had a bit more, had nothing done deeper in all the layers that you talked about. And as a result, by the time she died, just looked like this shiny, weird, almost Burns victim. And so facelifts, as a result, we always thought they're just what weird people do, those weird celebs, those weird people with too much money. Actually, there are probably several facelifts sat in this room right now. I can't tell who they are. I honestly can't. I have no idea if you've had a facelift or not, if you've had a good facelift. And actually, the tech, the technology, the science behind it, the techniques have evolved so much. We're treating all those layers that you mentioned. And we're now doing deep plane facelifts. We're treating things superficially. We're supplementing it with skin care, with all the stuff that you just mentioned, and with all the stuff that you mentioned, Nikita. And so as a result, you cannot tell. It's sat literally opposite you on the tube, and that's the sign of good work. And actually, those people should not be hiding away. We should be talking about it as openly as possible. And is it Churchy? Is that his name? The CEO of this place? Chesko. I was saying to him, look, actually, even a place like Lanzerhof should be embracing surgery because it's a fact of life. It's a bit like pretending that pregnancy doesn't exist. It's a fact of life, and surgery is a fact of life, because once, if you've got a pair of knickers and the elastic's gone, okay, there's nothing you can do. It doesn't matter how much you try and iron them or moisturize or nourish the elastic. Nothing's going to make the loose elastic come back. It's going to be tightening it up, taking it in. It's surgery, So actually, yes, we really should be, and we are, thankfully, there are people now talking in rooms like this, in the pub, in, you know, gatherings day in, day out about, oh yeah, I had a facelift, you know, what do you think? That's a good thing.
It's similar to boost around your GLP-1s. I feel like people going, nope, I've just worked out, and you know, it's actually having those open conversations, which can be really difficult, but it's important, especially with experts like yourselves. Can you tell me a little bit more about the surgery techniques that you mentioned? Because you mentioned deep plane there compared to these other facelifts you're saying that look quite scary. What techniques are you using in your clinic?
So it's not necessarily that deep plane or not deep, it's not necessarily that non-deep plane looks scary. Sorry, am I talking into this enough?
A little bit more.
It's not that the older techniques or the traditional techniques are necessarily bad. There's loads of really good, again, it's the 4 Ps, whatever you talk, you know, the right thing in the right person, the right place at the right time. All that, you know, that's what you want to do. So even a simple facelift in the right person can work really well. And there are some great surgeons doing really good work using not deep plane techniques. The idea behind a deep plane facelift, for example, and actually a lot of the surgery we do on the rest of the body is deep plane, because we're kind of moving muscles, we're resetting things. So let's carry on using facelift, because we've talked about facial, you know, changes as a result of weight loss. So a deep plane facelift is not only addressing the skin, it's actually addressing all of the other effects that gravity have. And I was mentioning, is it Nish? I was mentioning, if I do a headstand, I'm old, okay, I'm 57. I've got
You're
a whole...
not, don't talk about yourself like that.
I'm definitely old. But if I do a headstand, all of the I've got brow descent, so my eyebrows need to be lifted back up again. My cheeks have dropped, I've got jowls, I've got a neck. If I do a headstand, all of that stuff disappears. And actually, a lot of the volume loss, and I'm someone that I think we over-egg volume loss a lot when it comes to facial aesthetics and aging. I think with weight loss, yes, of course, you've lost fat, so you'll have volume loss. But with most aging, when most of us age, it's gravity, okay? And it's probably skin, sun damage to the skin, and general aging, thinning of the skin, which is again another fact of life, you know. So if I did a headstand, an awful lot of what I need to rejuvenate my face and make me look younger is corrected by getting rid of gravity when I do a headstand. And that's what a deep plane facelift does, because your muscles go down south, your skin goes south, your fat goes south. Yes, your bone thins out a little bit. Yes, some fat goes, but actually most of the problem is gravity. And so if we can correct gravity, and surgery is really good at doing that, with the people that do the rock stars of deep plane surgery that are out there, who do really good work with deep plane techniques, are hardly removing any skin.
Wow.
And the classic example, if you had the ponytail lift, you may have heard, Chachi Kao. He does endoscopic. He does these little cuts, puts a little telescope down, and then he will dissect all the layers, and then he'll lift them up and he'll stitch them using keyhole techniques, basically. And people look really good, because actually the Croydon facelift, the Sade facelift, tighten your ponytail, you look younger. That's what basically a facelift is doing. It's pulling everything north towards the sky.
Taking away gravity. At what point in the journey for someone who's on a GLP-1 or are losing weight naturally, what point should they come and see you? A bit like Catherine was saying, at what point do you consult someone like yourself? Is it at the end?
Well, ideally, it's holistic, okay? What's the definition of holistic? You treat everything, you know, together, synergistically. So in a way, I mean, no one's ever, it's so difficult. You know, it's a bit like, you know, you should be seeing your dentist at the same time as your plastic surgeon, at the same time as your GP, at the same time as your nutritionist, and dietitian and physiotherapist, and it's not going to happen. But in a way, it would be great if we were all sat there in a great big room like this, and there's one patient sat here, and we're all kind of saying, yeah, let's, so multidisciplinary. So in my NHS life, I do we call it complex abdominal wall reconstruction. So liver transplant patients who've had, you know, got great big hernias after surgery. I don't fix those on my own. I will sit there in a meeting every other Friday with a general surgeon, with a dietitian, with a radiologist who looks at the CT scans, we all look at that patient together. So the ideal, which we're quite a way off from because we're far too busy arguing with each other and fighting each other and trying to compete with each other for business. The ideal is that you come and see all of us together at the very beginning when you're thinking about, losing weight or getting your, your general health act together. So what's that going to imply? And I might go, look, you know what? If I saw someone like yourself, for example, I'll go, look, there's no role for surgery. Just get your diet sorted, your metabolism sorted. Maybe you need a bit of deeper work non-surgically, but you know what? Carry on with the skincare.
Thanks, Nav.
Yeah, no. I'm just wondering. As you're younger,
Free consultation.
Yeah. No, I'm not saying that about you, but no, I did not mean that. But someone younger, that's the stage you're at, okay? Yeah. Whereas if you're older and you've lost a bit of weight and you've got loose skin, then maybe yes, you need surgery. So if you came at the beginning, you started thinking about doing something, but you happen to be older, then yes, you need someone like me. And so there is no right point. You almost need to see everyone together.
Mm-hmm. Thinking of safety, at what point in this journey is someone, because we were speaking about nutrition and ensuring that your body is actually in a fit state, and that's obviously extremely important when it comes to surgery. How do you advise people to ensure that they are in a steady state when they're losing weight, but then also wanting to have surgery too?
I tell them to lose weight slowly. Mm-hmm. Again, simple. I'm not a dietitian. I'm not a physician. I'm not in any kind of. I'm in no way a therapist, a functional medic of any kind. What I want to see is slow weight reduction. I think that's the best way of doing it. I don't care how you do it. Gastric banding, diet, exercise, GLP-1s. Whatever the next magic thing is out there, and I think that's what we mentioned this earlier. I think that one of the problems with GLP-1s is it's a bit like AI. I'm a real techie. I love my gadgets. I saw a 360 camera there. I love my toys. Okay, but when it comes to AI, I really have not embraced it because there's a new one out every single week. It's Claude this week. It was ChatGPT. It was whatever. I have no idea which one is going to be the one that we end up using. So when there are lots of different ways of doing things, and GLP-1s are one of the many ways of losing weight at the moment, what that implies is that none of them are necessarily very good at the moment. Okay, so there are lots of different ways of treating scars, keloid scars, steroid injection, laser, freezing, compression with silicone. And we use all of these different things because none of those treatments are necessarily any good. So what I'm waiting for is, and I've gone off on a tangent, I'll come back and answer your question. What I'm waiting for is, let's work out which GLP-1 combination, which is the one that they're finally going to put in the water. Okay, which is the one that we find, like fluoride, which is the one that's going to sort us out properly. So your question was
about being fit, and you mentioned in a catabolic state.
So lose weight slowly. That no matter how you do it. Then the next point I was going to make is, if you're going to have surgery, don't be in the catabolic phase of losing weight. You do not heal at that point because your body is breaking down. If you have surgery, it has to rebuild. It's got to be in an anabolic state. It's got to be in a rebuilding state, not in the demolition phase. So you've got to either be lost your weight steady and maintaining, or maybe gaining a little bit of weight. I don't mind that. In a way, I actually quite like to see patients, I lost it and I got down to whatever, and you know what, it's been a little bit difficult over the last few months because I've kind of got on with the rest of my life and I'm not focusing on losing weight anymore, and I've gained a bit. Good, great, perfect.
How do you manage your patients' expectations? They're coming to you and they're saying, I finished this journey, I'm feeling fabulous, I'm at where I would like to be at, but actually I want this done. How do you say this may not be possible?
You just tell them you've got to be realistic. It's I am quite often the angel of doom because the trouble is, everything we've talked about, life is life, okay? And even after, I can't remember who mentioned it earlier, you've lost weight and tummy tuck maintenance, that's right. So, life carries on. Unfortunately, there is nothing in life that is kind to our bodies, really, as you get older. As time goes by, the sun, gravity, aging, generally stresses of life, nothing is so life carries on, and so if you come to me and actually there are. It's rare that I kind of look at someone going, you're too far gone, there's nothing I can do for you. It really is rare that I'll say that to someone. There's always something, okay, that we can offer. And even if it's not operating, you know, every surgeon knows how to operate. A good surgeon knows when to operate. A really good surgeon knows when to not operate. And the best surgeons are physicians who happen to operate. Okay, that's one of my favorite little sayings. I put it in every talk I give. So I'm not a physician. I'm a pseudo-physician because I'm a surgeon, but I know some really good physicians, so I can work alongside them. So I won't say necessarily no. The times I say no, and I do say no a lot, and I do turn people away all the time, is when I think people don't understand what they're getting themselves into. So if you come to me thinking, make me look beautiful and perfect, please, I feel fabulous, I'll go, that's not possible. I have to work with what I've got. We've got to live in the real world. I cannot turn you into whoever, name your current favourite celeb. That's, you know, I have to take what I have and make the best of that, and this is what I think I can do. And there are some people who just do not listen. And if you're not going to listen, this is not going to be a two-way process. And so yes, I can cut and stitch anyone, but if you're not going to do the aftercare, if you're not going to actually temper your expectations, and if you think I'm going to make you the perfect specimen, I'd rather not touch you, because I know that my life will be miserable after that, because you'll never leave me alone.
It'll be on your case.
Yeah.
And it's important to remember that it's still surgery. We're hearing of like lunchtime facelifts and mini facelifts, mini surgeries. Actually, it's still a surgery, and it really impacts the body.
However, what I was going to say right at the beginning, you mentioned the lady that turned up with the 4 vials of whatever the new drug is. That is basic. So yes, surgery is surgery, and we're all scared of surgery and cutting and stitching and scars and downtime and anaesthetic. And however, the story you mentioned of this woman turning up with 4 syringes is the equivalent, which thankfully doesn't happen in my world, and this is happening in the non-surgical world. Imagine you turned up saying, oh, by the way, I just cut a bit of my tummy off and I put a few stitches through. What do you think? Can you help me now? That's basically what's happened. And so when it comes to, you would never do that. Again, no one in this room is going to operate on themselves. If you're taking all these drugs off the internet, you're effectively doing that. You're doing rapid weight loss without proper guidance. And you would never do surgery without a proper surgeon doing it. I mean, there are cowboys out there doing all sorts, but you'd never, I mean, no one in this room, I expect you all to be above average intelligence. We would never do that, okay? We would never go to someone totally random and expect them to cut our tummies and do a tummy tuck on us or a facelift on us. Or if we did, we pretty much know what the consequences are going to be. So so the same thing, turning up with random drugs, yeah, that's just as crazy in my world, in my opinion.
That's a really important point to end on, Naveen. Thank you. Genuinely, that actually summed up the conversation quite beautifully, that we have to trust in the experts, and this is a journey, one to be taken with the professionals, not something to go with on our own.
You know, trust me as an expert. I will trust you as being intelligent enough to know your body and know, you know, something doesn't feel right. When someone comes to you, a good doctor will listen, a bad doctor will dismiss you and send you off. And the same thing's true for surgery. You know, you come to me going, look, this bothers me. I'll go, okay, let's see what we can do. Or maybe, you know what, the risks are too much, don't do it. But yeah, absolutely.
Thank you so much. That brings us to the end of the conversation. Thank you all. Like I said, summing it up beautifully, that actually it's to be guided by a professional and to understand the implication of these medications on all parts, our bodies and our minds, most importantly. That we do have some time for questions and answers if anybody does have any questions.
What about the oral medications that are happening? So what's the advantage of that as opposed to injection? Is that more effective?
They're not necessarily more effective. I mean, it's just about the route of administration being easier. Some people prefer to have a pill than injecting themselves, although the needles are so fine that, you know, many people are absolutely fine with it. Some people like to just take it once a week and then not have to think about it. So I think it's just personal preference. The thing about the oral, though, as well, is it gets metabolized through the liver, so it's downside potentially to that.
Are they available in the UK then?
Yes.
Okay.
Yeah.
So like that they're just available privately at the moment, not the NHS, is that right?
Correct.
Yeah.
Yeah.
So, any other questions?
I have two questions actually. So one of them is for Dr. Nikita. So as you were talking, I actually did a bit of stalking because you've got your Instagram here.
Oh dear.
The power of
Literally
technology.
only got on Instagram about a week ago.
Oh, okay. So I just quickly had a look and I saw that you've got Lanzerhof there.
Yeah.
Assuming that you work as part of Lanzerhof.
Yes, I do. Yeah.
So what I wanted to ask you is, I mean, I know we're talking about weight loss mostly today,
Yeah.
but as a functional health doctor, what's the most like common symptoms or problem like patients come to you for? Like what's the most common issue?
What in general, or related to weight?
No, in general.
In general.
Related to weight.
Oh gosh, a whole spectrum of problems. So
What's the one most common?
I think fatigue.
Fatigue.
Yeah.
So not like hormonal issues.
That too. Sometimes they start with fatigue and then we find out there's a hormonal issue underlying it, or it might be perimenopause and menopause. Literally, brain fog, for example, is another one. Chronic pain is another one. Irritable bowel, autoimmune conditions. There's a whole spectrum. I think because I am a generalist, nothing is out of bounds. Everything is welcome, and we figure it out.
And as a functional health doctor, you kind of see everything as a whole, right?
Correct.
So do you see them like, in terms of the journey, is it like several appointments you need, or is it like, do you see them in like 2 appointments? How does it usually?
So it really depends. I mean, I don't want to, I don't take this the wrong way, but I don't want to keep seeing people. I want to give them the tools to get better, and then they go off and do what they have to do. So it really would be around the diagnostics, getting to the root cause of what the problem is, finding where the systems aren't functioning optimally, investing in there, and then really considering what does that individual need and what can they be doing themselves. It's about partnership and ownership of their condition. It's not about me solving it.
I have one more question, sorry, that's for Catherine, Dr. Catherine. So basically, in terms of, because you see all of these celebrities, they've had like, I don't know, whether after weight loss or even after pregnancy, they have like these like amazing abs. Like I always wonder, how do you tighten, I know you briefly touched up on it, but like how do you get like really tight? I mean, hopefully like it's at a stage where it doesn't need surgery. So like before surgery, at what point, like what kind of treatments do you need to do to get really tight abs?
It's a great question.
Probably going to the gym.
Yeah,
We're all listening.
I guess is your question around skin tightening? Is that what you're saying? Or okay, yeah. So again, really, it's a layer by layer approach, and there is the extreme end of obviously needing surgery, and that is more often than not the case. I find particularly with body with massive and extreme rapid weight loss, particularly with GLPs. Generally speaking, I would just go, do you know what? You could spend several thousands of pounds trying to tighten your skin, but actually all you need to do is go and see him.
There are people, and I think there are an awful lot of the pictures you're seeing, either they're fake.
Yes,
Okay,
agree.
And I think, and I cannot remember her name, and I'm having a blank, the one who's just split up from Nick Jonas, or...
Anyway,
whoever she is, but she's there displaying perfect abs after having given birth and instantly came back, and there are, and you hear about it, and I've never taken part in it, but people having muscle tightening tummy tucks at the same time as their cesarean.
Yeah, it's a thing.
Which sounds crazy, but
Yeah.
I think it's a thing that's out there. So,
Yeah.
anyway, I'm not sure. I don't think it's a big thing. I don't think everyone's out there doing
But I
this.
think you're absolutely right.
But
in
I
terms of
think
the celebrity
I think a lot of
culture, it's a
people.
big
I think a
thing.
lot of what you see, you've got to take with a pinch of salt.
Yeah.
Filtered AI, fake, whatever photos, or they're not telling you what they've done.
absolutely. On the less extreme examples, really for me, again, it's a combination, and my kind of go-to combination, generally speaking, is a mixture of injectables and energy devices, and usually that looks like sculpture body. So let's say for pregnancy we do quite a lot of sculpture in the abdomen, and then we'll also do courses of things like radiofrequency and maybe resurfacing with laser. So and also body skincare is something that's very overlooked, I find. That alongside obviously things like nutrition, physical fitness and things are obviously really important, but there's not really a one size fits all thing really. And actually it's interesting, so Nish was asking me earlier about what would your go-to one thing be for skin tightening, was your question, wasn't it? There isn't one. It's absolutely a case-by-case discussion, and usually it's some form of injectables, obviously holistically nutrition and physical therapy, and then probably some form of energy device.
You can use sculpture everywhere. The way you're speaking, I'm like...
It's licensed for quite a few places now. So facially it's been licensed for 25 years. It's now licensed for neck, for décolletage, for arms, for abdomen and for bottoms and thighs. And it does a great job in the right person. Yeah. But it's a good patient selection is key.
I think there's also one of the things we underplay, by the way, to answer your question, is probably if you're going to lose weight rapidly, so liposuction is getting rid of a whole load of fat quickly. And what do we do after liposuction? We make you wear garments, okay, for 6 weeks, 3 months. I think if you're going to take GLP-1s or if you're going to lose weight, however, after pregnancy, which is rapid weight loss, your skin has to shrink quickly, support. You know what, because when you lose weight rapidly, after liposuction is the classic one that I know to talk about, if you do liposuction, straight after liposuction you get swelling. Okay, the space where the fat used to be fills up with fluid. If you let that fluid, heavy, soaked tissue just hang there, it will literally hang, the skin stays stretched and you end up with loose skin. I reckon the same thing is what happens after pregnancy. After rapid weight loss with GLP-1s, gastric bypasses, exercise diet, whatever. So I wonder whether we should be getting all of our patients to strap themselves in if they're on GLP-1s.
You're doing yourself out of a job then, Nav.
Yeah, no, absolutely. Because again, a bit like Nikita, I don't want to. I'd rather you did it yourself. Because you know what, doing it yourself is better than anything I've got to offer with a knife and fork. It really is. And actually doing it naturally is always better, and doing it subtly is always better, rather than, surgery is, I mean, it's not a last resort, but it should be. Okay, so if you can do everything you can to avoid the knife, do.
Thank you. Thank you so much. I think our speakers will be here for a couple of moments if you have any more questions. All that's left from me is a big thank you to all of you for being here. It's a really important conversation and we really appreciate you being here. And finally, a big thank you to our beauty triangle.
Thank you.
Thank you so much. We hope to see you at our further events. There are some QR codes and things on your programme, so if you'd like to join any more discussions that we're having in any of our content, please do follow along. Thank you.